the invitation to speak today. I moved from New York City, Manhattan to LA about 10 years ago, 12 years ago. And my practice at New York Hospital Cornell, most of my patients asked me why I was going to La La Land. It was actually a great transition for me, and in the process, I sort of got the Hollywood bug, so that's why I was sort of an independent filmmaker on the side, which is my plan B in case the floor drops out of Medicare medical medicine. So I'm actually the director of the Telehealth committee over at Children's, and I was charged with that 6 years ago. And 6 years ago, we put together a bunch of pro formas looking at fee-for-service telemedicine, and every single one bled red, deeply red. And so we actually just shelved it because I couldn't get buy-in from the leadership to finance something that would have great value for the patients, great value from a care standpoint, access standpoint, but wasn't gonna generate revenue. And so for about 3 years, we put that on the shelf, and then about 2 or 3 years ago, we came up with a new model that actually is now very profitable for us and is now driving how we look at healthcare to achieve our mission statement as a hospital. And so I'm gonna take you down that journey. I have no financial disclosures. This is my world. I'm a retina surgeon, and I focus solely on children. And as such, when you look at my practice, this is what you see. Now, most people would find this very appealing, very nice and warm and fuzzy, but I have to give you some context for this picture. In LA County, there are 3 million children. That is greater than the combined population of San Francisco and San Jose. And the other thing I need to tell you is that most of the healthcare systems outside of the local county system do not take care of Medi-Cal children, which is our state version of Medicaid, which represents 70% of all children in the state of California. So how do you take 3 million children, of which 70% are in Medicaid, and get them the access to the subspecialty care they need? From our hospital standpoint, that is our true mission. We want to make sure that all children get access to our system, especially given that we're the only healthcare facility in the state of California, children's hospitals, that's ranked in the top 10. So when there's a child with a very specific high-level issue, high acuity, they need to get into our system. Yet, if you call our appointment center, we're now scheduling in November of 2019 as the next available. So if your child gets sick and can't make their appointment to see me, they're getting kicked out a year from now, which is unacceptable. So when I look at this, this is not what I see. This is what I see. It petrifies me that there's a child somewhere out there in that queue who could be going blind, and I don't even know it. The dilemma is that we're now punching out to 500,000 outpatient visits annually in our organization. And we are like, I converted a resident office and a back procedure room into an exam lane just to squeeze out that little bit much more. And the way our hospital is going, they want to scale to meet this need. Now, they can scale physically. They can make more square footage, they can buy more property, they can set up more ACCs, but where are you going to find another pediatric retina surgeon who does this full time? So that's the problem. We have a healthcare workforce that cannot scale as quickly as our hospital requires us to. So we have this delta that we have to address. And will that delta be addressed by the current model? Do we just keep calm? And this is a very common phrase at my hospital, and that's not gonna do it. Instead, being in Silicon Valley, this is how we have to approach this. Now, I will say, if you look at our hospital and you were to describe it as a car, this is our hospital. We have 600 pediatric subspecialists in pediatric cardiology, pediatric ophthalmology, all down the line. And so if you have a child you have to take to some destination, medical destination, and you put that child in our car, we will get you there. But is that the scalable model we need to address the delta? Or do we need to look at this? Do we need to become something that's more efficient with bigger capacity to do things at a lower cost? Which one of these is our future to address the needs of the children, of the 3 million children in LA? And in the process, do we end up becoming the spork of healthcare? Do we try and do too many things and not do any of them well? So let's take a look. The Hummer is great for initial evaluation, acute management, surgery, something that's really active. You don't know what obstacle is going to be in front of you, so you have to put them in that car. But what happens after they get their diagnosis? They now have their treatment plan in place, and now you just need follow-up exams. Well, that would be the PRIAs. So we partner with federally qualified healthcare centers, which actually have a completely different payment model. And they're specifically designed for the underinsured, and they live in the communities where our patients live, meaning that most of our patients are on Medicaid. So one solution would be to go ahead and set up solution A, which is all of our stable patients get migrated to the FQHC. That frees up space at our main campus and also puts them closer to home. The problem is our children are so sick, even our stable patients are at risk of relapse and other issues. So how does the FQHC know to send the patient back? Because they don't have that level staffing. Solution B, we send our allied healthcare practitioners, our CHLA employees, to travel with our patients to these FQHC community clinics. And then when the patient becomes active or perceived to be active, they send them back. The problem with solution B is the advanced healthcare practitioner, whether it be a nurse practitioner, PA, or in our case, optometrist, may not know exactly which ones absolutely have to come back, so they will over-refer to compensate for that. The third version, which is what we've arrived at, is a virtualized version of ourselves, where when needed, the optometrist can do the exam in real time with the doctor available. So this is that version of that. I don't know if we can turn up the volume on this. You can kind of get the sense of what's going on. I don't know if that's, I can basically tell you what's going on in the audio track. Whoops, what happened there? Okay, are we gonna try it again?
Let's just try the 12.
So this is being streamed in real time using a hardware codec.
Let's start with the 8
This was
again.
part of a larger study that was performed
One more time?
where Dr. Nalasamy was down the hall in the FQHC, but doing the initial exam remotely, completely. And we're streaming it through these pivot head goggles that are 1080p at 30 frames per second. All right, great. Let's go back to the slide. Can we do that? Or do I have to do that? So in that study, which is a prospective study, she did 262 exams. 99%, the remote exam was identical to the in-person exam that she did. She basically walked down the hall, popped her head in at the end, did a little candid camera. I don't know how many people have even seen that show, so I'm dating myself. And actually signed up 30 surgical cases through that initial pilot. Parents were extremely happy with this, as we all know, in terms of outcome. But let's get down to the brass tacks. Why did I go this route? This is why I went this route. When we actually looked at the financial aspect of this, we found that the access improved dramatically because we had these optometrists filter feeding, many optometrists, multiple sites feeding into our one doctor. So the next available dropped. The number of new visits that we could generate annualized went up accordingly, and the RVUs went up. Now, what's interesting about this RVUs, there were much fewer exams performed on a telemedicine day, but because they were all high acuity, the RVUs went up. And most importantly, from a surgeon's standpoint, we dramatically increased her surgical volume by 40% for every day that she's in clinic. And then this is the bottom line. Her annualized collections went up by about 40% because everything was new or high pathology or went to the OR. So when I talk to my CEO and so half of my job is trying to explain things to my CEO. And I was trying to figure out what is the ideal metaphor to show the power of telemedicine to improve access for Medi-Cal patients, and I said, this is the example. If you think about it, there are FQHCs all throughout California that have capacity, but don't have necessarily the patients, and specifically the complex patients, because their local community doctors can't handle that. We have the patients and we have the expertise, so we are going to join this sharing economy where they have the rooms, we have the people, and we're going to make the Airbnb of healthcare. This allows us to maximize capacity where it's available, and that way we avoid becoming the spork of healthcare, because we're not going to assign very valuable resources to do something that we don't do well. And in the process, we can make this hybrid version of where we want to be. and allow us to meet our budgetary goals, meet our patient access without compromising quality of care or patient safety. There's a number of people who've been involved in this project, and it sort of does take a village to sort of make all this happen, so we're really excited. And now I actually do have the attention of my CEO, and so we're going to be looking at a larger rollout for other disciplines. Thank you very much.
Sometimes for long questions. Okay.
You mentioned the increase in RVUs. Now, how does that tie into our earlier discussions about telemedicine potentially being something that bends the cost curve down, not up?
Mm-hmm. So I think when we look at, so those children that generate the high work RVUs are out there. And this is maybe a unique situation for us, because we have a 1-year wait to get into our system, and there are 3 million children in LA, those kids will ultimately need those surgeries or procedures or diagnostic tests. They're just gonna get it really, really late. So from the state of California CCS standpoint, those kids they will have to pay, and maybe even more because it's delayed, they'll have to pay for those RVUs ultimately. What we're trying to do is jumpstart it so they get into our system quicker. So I think from a cost perspective, from the state, it's a wash because they're gonna pay for it anyway. But from our perspective, we can actually bring them in really quick and get them cared for. So our case mix index goes through the roof, whereas from the state standpoint, they're happy because ultimately they're gonna get to us anyway. Yeah.
Hi, great presentation, by the way. With obviously, you're having to get the reach out. What about working with like the county hospital systems, or like they're kind of in charge of population health, and then like the schools with the whole mental health push in schools and all that. I mean, you'd get in at the at the right time, and you have the patient base. So have you guys thought about that approach?
Yeah. So within the county system, actually a majority of the kids, because we do take Medicaid, Medi-Cal, a majority of the county eligible children actually come to us first anyway. And so that's part of it. But we do view the LA County system as a good partner potentially. Regarding schools, it's interesting that you mentioned that because we feel that schools need to be the new healthcare delivery platform for the future. Now, there's a lot of legalities about that because they're not technically a CHLA patient at that point, especially if they're new. It's one thing if they're existing chronic patients. But we do believe that going forward, that's going to be really important. So we've actually had an ongoing relationship with the country of Armenia and their Ministry of Health, and they're allowing us to greenlight. We're actually in the process of building a patient-owned free EMR for the developing world that we're piloting in Armenia that will allow the school nurse to have full access because the parent is the owner. The parent is the admin for their child's EMR. So working with SADA Systems, we've actually started that process. We just came back from Armenia on Saturday, and so that's actually something that if we can pilot it in a developing country, show the efficacy and the value, our plan is to bring it back for the children of LA.
That's awesome. Maybe one last question.
Have you used telemedicine in the context of taking a fundus image and having a central place for immediately screening the patient?
Yeah, so we also run an asynchronous store-and-forward ROP, retinopathy prematurity telemedicine network that captures all these fundus images, which is something that I'm an ROP specialist, so that's something that's specific for me. It basically allows me to cover what will be 15 hospitals across 2 states, both Phoenix and Southern California, for a total of 600 level 3 NICU beds. And because of the time component, I basically do that at night. So it doesn't require me to shut down a clinic, and I can do it pretty much anywhere. I was actually doing it just like 30 minutes ago in the back. But that's actually a very important modality, and for me, it actually is helping me underwrite the cost, and it allows me to reinvest in my own division.
Tom, thank you so much for that phenomenal talk.